Hello, my name is Sebo Casanova, and this is my ID. Okay, so I'm going to present my poster. The title is Psychiatric Mental Health Nurse Practitioner or PMHNP led telepsychiatric and mobile crisis response for rural youth in psychiatric emergency, boarding time reduction, and transition to follow up care. The clinical problem I am addressing is psychiatric boarding among rural youth. I want to frame this as a more than an emergency department flow issue. When a child or an adolescent in psychiatric crisis remains in the emergency department for prolonged periods of time, while waiting for psychiatric evaluation, placement, or discharge planning, that delay can increase emotional distress, reduce family trust, and limit timely mental health treatment. In rural communities, this problem is even more complex because of psychiatric provider shortages, limited inpatient psychiatric beds, long-term travel distances, transportation barriers, and fewer community-based follow-up resources. The purpose of this project was to examine whether a PMHNP-led telepsychiatric and mobile crisis response model could improve care for rural youth presenting to the emergency department with an acute mental health crisis. My bigger question asked in rural youth experiencing an acute mental health crisis and presenting to the emergency department, does a PMHNP-led telepsychiatric and mobile crisis response model compare with standard emergency department boarding and traditional referral process, reduce psychiatric boarding time, and improve successful transition to follow-up mental health care? The alternative hypothesis was that this model would reduce boarding time and improve follow-up care. The null hypothesis was that this model would have no significant effect on boarding time or follow-up outcomes. For this method, I conducted a structured literature search using PubMed, Medline, PsycInfo, and Google Scholars, and Crossrain Library. The search focused on literature from 2021 through 2026, key terms including rural youth mental health crisis, pediatric psychiatric boarding, telepsychiatric mobile crisis response, emergency psychiatric care, and PMHNP-led care. Inclusion criteria were peer-reviewed English language studies related to youth psychiatric crisis, rural access, emergency psychiatric services, telehealth crisis care, or transitions to follow-up. I excluded adult-only studies, non-peer-reviewed sources, and studies unrelated to crisis telehealth or emergency psychiatric care. After screening the evidence using a PRIMA guided process, 7 studies met the final inclusion criteria. This review was guided by Pipleo's interpersonal relations theory, which is highly relevant to psychiatric crisis care. Psychiatric emergencies are not only about finding a bed or making a referral, they also require therapeutic engagement, trust building, emotional containment, and clear communication with both youth and the family. In Plepleo's orientation phase, the PMHNP helps the patient and family understand the crisis and the immediate plan of care. In the working phase, the PMHNP completes psychiatric assessment, risk evaluation, stabilization, medication considerations when appropriate, and family communication. In the resolution phase, the PMHNP supports discharge, readiness, safety planning, and connection to follow-up services. Telepsychiatric does not remove the interpersonal role of nursing. Instead, it extends that role into rural settings where in-person psychiatric care may not be available. Overall, the evidence supported telepsychiatric and mobile crisis response as promising strategies, but the findings also showed important limitations. Several studies suggested that mobile crisis services may reduce avoidable emergency department use by assessing and stabilizing youth in the community when safe and appropriate. Other studies supported telepsychiatric as a feasible way to expand psychiatric consultation in emergency and rural settings. Together, these findings suggest that technology-supported crisis care can improve access to psychiatric expertise, support more timely clinical decision-making, and reduce unnecessary strain on emergency departments. However, the evidence did not directly prove that a combined PMS-MP-led telepsychiatric and mobile crisis model reduced boarding time, especially among rural youth. This is the most important part of the synthesis, and the literature supports the individual component of the proposed model, including telepsychiatric mobile crisis response and PMS-MP workforce expansion. However, no study fully tested the integrated intervention and the exact population settings and outcome structure described in my previous question. Therefore, the evidence provides partial support for the alternative hypothesis, but it is not strong enough to reject the null hypothesis with confidence. A key finding from the patient and family-centered evidence was that rural families' values were not valued than speed. So they want clear communication, emotional safety, and a sense that the child is being heard. This is clinically important because reducing boarding time alone is not enough if discharge planning is rushed or fragmented. A strong PMS-MP-led model should measure both system outcomes such as boarding hours and patient-centered outcomes such as safety planning, family understanding, follow-up completion, and satisfaction with care. Evidence related to policy-insured youth also highlighted equity concerns, suggesting that psychiatric boarding may disproportionately affect vulnerable population. This reinforces the need for a crisis model that improves access without worsening disparities. For clinical practice, my recommendation is that rural emergency departments integrate PMS-MPs into psychiatric crisis workflow through telepsychiatric partnership and mobile crisis collaboration. The PMS-MP role should include rapid psychiatric assessment, suicidal and violence risk evaluation, diagnostic and medication consultation, family-centered communication, and disposition support. Most importantly, the transition plan should not end with a basic referral. It should include a confirmed follow-up appointment, direct communication with the receiving provider, medication reconciliation, a written safety plan, lead and means counseling when indicated, and clear return precautions. In other words, this model should create a warm handoff rather than a passive referral. There are also important implications for nursing education. PMS-MP students need preparation in rural crisis care, telepsychiatric etiquette, emergency risk assessment, interpersonal teamwork, and care coordination in limited resource settings. Simulation can be especially useful because it allows students to practice high-risk scenarios such as suicidal ideation, family conflict, involuntary evaluation, and discharge planning when inpatient placement is unavailable. Future research should proportionally test an integrated PMS-MP-led telepsychiatric and mobile crisis response model. Important outcomes should include average boarding time, emergency department disposition, repeat emergency visits, follow-up attendance within 7 and 30 days, patient and family satisfaction, safety outcomes, and cost-effectiveness. In conclusion, telepsychiatric and mobile crisis response demonstrate convergent promise for improving psychiatric access and reducing emergency department burden in rural communities. However, the specific effect on an integrated PMS-MP-led model on youth psychiatric boarding and transition to follow-up care remains insufficiently studied. PMS-MPs are well positioned to lead this model, but stronger prospective evidence is needed before definitive conclusions can be made. Thank you.